The Ninth Senate is coming to an end, and it becomes important to review the activities and programs of the standing committees of the National Assembly. This is the standing committees. I am Ignatius Nkwo, and in focus today is the Senate Committee on Health. Our guest today is the Chairman, Senate Committee on Health, a practicing medical doctor, senator representing Kwara Central in the Senate. Thank you for joining us on the program.
Thank you very much.
Well, I would say congratulations that we are coming close to the end of the Ninth Senate. I know there are some of your colleagues who started with you, but they are no more. But we thank God that God in His infinite mercy and with kind of work you did in the Ninth Senate, we're able to see this held and hearty. I would say congratulations for coming to the end of this program, of this Ninth Senate.
Thank you very much.
Now, can you tell us, how will you describe the various activities of this committee? Generally, in summary, would you say that the committee had an agenda? Did they achieve the agenda just like the bigger chamber as the Senate itself?
Thank you. The Senate Health Committee, or National Assembly Health Committees for that matter, we indeed have agenda. When the leadership of the committees were announced in July 2019, in the Senate, we have two health committees, or two committees in charge of the health sector. My committee, which is the Senate Health Committee, Secondary and Tertiary, and Senate Committee on Primary Health Care Communicable Diseases. Whereas in the House of Rep, the sector was divided into three. House Committee on Health Services, House Committee on Health Institutions, and House Committee on AIDS, TB, and Malaria, known as ATM. So those five committees, when the leadership were announced, we came together sometimes in August 2019 to set an agenda for ourselves. In fact, at that time, the membership of the committee had not been announced. The membership were announced in September. So, but the leadership has announced, the chairman and vice chairman. So the 10 of us came together and we set out agenda of what we intend to achieve. And to God be the glory, I think most of the items we listed that we said we want to do or achieve, we have been able to accomplish them. I can read them out. One of the first things that we said is that we look at the healthcare financing in the country, and we saw that the health insurance, as we do have it, has a minimum coverage. It was less than 5%, or just about 5% of the total population that is covered. And there is for us to be able to achieve universal health coverage, we need a robust financing mechanism. Hence, we set out ourselves to review and the health insurance law and make it to be in tune with what we are able us to achieve as health coverage. And to God be the glory, I work on the bill, that is the National Health Insurance scheme, as it was the NHIS law, which is known as NHIS CAP N42LFN 2004. So a new bill was proposed and was submitted and was sponsored by me, and it went through all the readings. It was eventually passed. It was passed for the first time on the 21st day of July 2020 by the Senate. Of course, it went to the House of Rep. We were able to work with our colleagues there to get a concurrence. When it was sent to the President for assent, the President rejected it for certain reasons, because there are certain things that the Ministry of Finance kick against. But we reworked on the bill, and eventually it has been passed into law. Now we have a new National Health Insurance Authority in the country, which the bill, or that act now, provided, one, that health insurance is mandatory for all residents in Nigeria. So with this, it means everybody in this country must have a basic minimum package health insurance once this act is being implemented. And I think the implementation has started, because, for example, now the authority is discussing with Foreign Affairs that anybody visiting Nigeria, part of visa requirement for you to enter this country is for you to pay for insurance, just like you pay to go to Europe or go to UK or America, that you must have health insurance before you enter the country. But two, to be able to make this possible for citizens of this country, insurance is about pooling. It's about bringing money together. And we know that means you have to pay a premium. But we have very high level of poverty in this country, with almost half of our population living below poverty line who may not be able to have means. So these are known as the vulnerable group. So the law, the act provides for the establishment of a vulnerable group fund to take care of those populations, which is about 3 million. In addition, the law provided for the use of e-technology to be able to make our insurance to work. And the law, for the first time, recognizes and bring in focus the various state health insurance agencies, so that the National Health Insurance Authority will act as a regulator and be able to moderate what is happening in the system. So that's one of our agenda, and I think we will be able to achieve this. The second agenda was, when we came in, the National Health Act, which was passed in 2014, which the last assembly in 2018 provided fund under the Basic Healthcare Provision Fund. A guideline was developed. So when we came in, we saw that that guideline was not in tune with the act, and hence there's a need for a review and a reproduction of a guideline that will be able to bring forth the intent of the act. So we work with it, because the provision of guideline is executive function, but we oversight that. We had series of discussions with the Ministry of Federal Ministry of Health, the stakeholders, and to God be glory, we have a new guideline now, and the Basic Healthcare Provision Fund has started to function as it was intended by the National Health Act that was passed. Just to put in, National Health Act itself, we look at it that in the education sector, it is 2% of considered revenue fund that is being given to education, basic education. So for basic health, it was 1% that was passed in 2014. So one of the bills that I sponsor also is the National Health Act Amendment Bill, which has been passed by the Senate. It's awaiting concurrence in the House of Reps now, which is proposing 2% considered revenue fund for the health sector as well, to provide basic minimum package of health. This will also complement the insurance, as we said, because the basic healthcare provision fund is split into three, essentially. 50% of it was for insurance. It means if we increase the funding from 1% of the considered revenue fund of federal government to 2%, we have more money to be able to cater for insurance, and that money also goes to the vulnerable. It's one of the sources of fund for vulnerable group fund. Second fund is for the basic, is to primary health care agency to provide the supply side, that is human resources, drugs, and so on. So of course the third part is the one for health emergency. So one of the things we observe in the implementation of the act was also about the interpretation of the 5%, which is meant for health emergency. Yes. There is a conflict between what we call the public health emergency, which the National Center for Disease Control undertake, and emergencies that are other emergencies, trauma, accident, any emergency, which was the intent. So after the passage of the National Health Act 2014, the NCD's Act was passed in 2018. It provided for it to get funds from the basic healthcare provision fund. It said it will have 0.5% of the 5%, whereas what it meant was half of that. So the new amendment, which has been passed by, which I proposed, which I sponsor, has now clarified specific percentage for National Center for Disease Control and a specific percentage, which is 3% and 2%. 3% of the 5 of the total money will go for national health emergency, while 2% will go for public health emergency. So one of the things again which we observed was the issue of having an effective coordinated emergency response in the country. Not the public health emergency, but the natural emergency. If there's any accident, if anybody collapses or so on, we don't have an ambulance system that one can call that will come and take somebody to hospital and without thinking of payment to be treated. So one of the bills that are sponsored, which has been passed also by the Senate, is the National Health Emergency Agency Bill, which is to be able to establish an emergency system, a coordinated ambulance system for the country. Already the country have a 112 call system, which if it's called, you should be able to attend to emergency. But if you call 112 now, there's no organized ambulance system, there's no funding for that. So that law has been passed by the Senate as well. It's part of our agenda that we set up. And this one, we are waiting for the House to concur to it as well. But before then, the Ministry of Health has taken on, we work with them. They have set up this ambulance system using the funding from the Basic Healthcare Provision Fund, as well as direct budget allocation, which was given to them in the 2021 and 2022 budget. So they have started pilots in FCT here with the ambulance system. That's one of our agenda. The other core agenda which we do have is about looking at the tertiary healthcare system, because the federal government responsibility is for tertiary. 70% of the budget of Federal Ministry of Health goes to tertiary healthcare services. We have quite a number of them, almost 61 federal teaching hospital, federal medical center, and specialized hospital together. So we had a lot of time to oversight on them, to look at their internally generated revenue, how they are collecting, how they are utilizing, and how they are improving their services. So a lot of our oversight time as a committee was spent on looking and working with the leadership of all the federal tertiary hospitals to see how they can automate their system. With automation of the system, they'll be able to prevent leakages in terms of the revenue generation, and we scrutinize more how they are utilizing this idea to be able to improve services for the people. Of course, we under the tertiary healthcare also, there is the issue of training. Before we came on board, I think it was 2018 or 2019, the residency training program was funded. Bill was passed or law was passed, but it wasn't given effect. So when we came working with the Federal Ministry of Finance, Federal Ministry of Health, we were able to effect this, and for now, the resident doctors get their training fund. Through that, we will ensure that the funding for it is put in the budget. So these are some of the key things. Of course, we do have certain other things, because one of the major ones is the mental health system. WHO define health as not merely the absence of disease, but complete physical, mental, and social well-being. Yes. Now, with hospitals, most of the things we do there are the physical health. Of course, the social well-being is not in the health sector. It's other things that we call the social determinants of health, like provision of water, clean environment, the economic sector, and so on, which climate, what we call it, which is part of environment. Those ones are social well-being. But mental well-being has not been effectively cared for in this country. When we came, one of the things we organized is that there's no legal framework that regulates and that provides for policy for development for mental health. So I also took it upon myself. I sponsor the mental and substance abuse bill, and that law also, to God be the glory, has been passed by both houses and is assented to by the president. And now the law we had before is the Lunacy Act, which was not a national law for itself. It was a regional law, because it was applicable to Lagos colony in 1918 when it was passed. So of course, it was adopted in 1958 for independence. So we don't have a national law for mental that guide mental health, but now we do have one. And with that law, a department will be created in the Federal Ministry of Health. We didn't want to be creating agencies, so the department will be in charge of policy formulation, monitoring, and ensuring the implementation of various mental health programs in the country. And a specific fund was also provided. So these are some of the things, the agenda we set out to do. Of course, if I want to go on, it wasn't part of our agenda, but behold, barely 7 months when we came on board, the world experienced a pandemic that has never been seen in many, many years, many decades, or even centuries. The COVID-19 came on board.
Yes, I was coming there.
So, and as such as a committee, we have to respond to this. And I think that, of course, took most of our attention, not only of our committee, but the entire National Assembly. The leadership provided support to us, because COVID not only affected health, it affected the economy. Just like we always say, it affected both our health and our wealth. So one of the major activities of this committee, or the committees combined, the health committees, was our work on the COVID-19. We used our foresight responsibility to be very proactive, right? Even before Nigeria got its first index case on February 28, 2020. Earlier before then, as a committee, we came together both Senate and House of Rep, to undertake a visit to our ports, because our assessment was that if at all Nigeria, the disease would be imported in Nigeria, because there was none then, it will have to be imported through the point of entry. So we try to assess the preparedness of our port system So we went to Abuja and Lagos port as well as Apapa and Tinkan, because if it's not by here, it may be by sea, because people travel by sea, particularly the sailors and so on that bring goods to the country. So we were able to look at this. We provided necessary advice and what I would call directive as to reparation. So behold, that was why when the first case came, it was easily detected. When the person passed through and they did the test, they were able to follow up, and then we saw the case. Now, when the first case was now detected in Lagos, when the person was admitted in Lagos, we saw that we don't have facilities even in Abuja for isolation. So NCDC was then constructing an isolation center in Gwagwalada Federal Teaching Hospital there. So, but because we need to be prepared, so we discussed with leadership. The chairman of the National Assembly, who is the president of the Senate, actually led a team comprised of our committees to go to Gwagwalada to be able to inspect. And following that inspection, we were able to give necessary directive to the executive and the Federal Ministry of Health to get necessary equipment and facilities to make the Gwagwalada Center to be functional. And we expedited action for the one being constructed to be finished. So this enables the first set of cases that were seen in Abuja to be taken care of there. But beyond this, we had several engagements with the Presidential Task Force, as it was, which later metamorphosed into Presidential Steering Committee. And in 2020, the National Assembly had to come up with a supplementary budget, working with the executive. And that supplementary budget, we were able to provide necessary infrastructure that enable the country to respond to the COVID-19 and even prepare for any similar outbreak that may happen. As at the time when COVID-19 started in February 2020, we have only 2 functional molecular labs in the country. One in Lagos and the reference lab of the National Center for Disease Control in Abuja. But through our interventions, we now have in 61 federal teaching hospitals. That is teaching hospital, federal medical center, specialized hospitals. Specialized hospitals are the orthopedic center, the psychiatric hospital, the National Obstetrics and Fistula hospitals. We have about 3 of them across the country. National here, national high. So all these combined about 61. So each of those 61 have a functional molecular lab now that can test for not only COVID-19 virus but any kind of similar viruses, and can be used for research in molecular science. But in addition, we provide about 53 of them with isolation centers, which is 30-bed isolation center in each of these hospitals. That infrastructure was not there before. You recall that when the COVID-19 was really ravaging, it's temporary isolation center, tents were, but now all our federal hospitals have at least 30-bed isolation center. Some have more than that because NCDC was provided with some money also. They provided zonal isolation center in some of the hospitals in the state. Then the other one was the intensive care unit, ICU, because one of the things that leads to death in COVID-19 was the issue of when it becomes severe in the patient. Patients have hospitals require ventilators and so on. So our intensive care unit. Not all our hospitals had effective functional ICU. Most of them that do have, maybe they have 4 or 5 bed ICU. So we will be able to provide for at least 53 of the hospitals. They have minimum of 10 bedded ICU centers with functional ventilators. Then in addition to that, oxygen plants through the different funding mechanisms were provided for all these hospitals so that the hospitals are able to provide oxygen. So if there are any kind of condition that require patients to receive oxygen, now we are better prepared than we were. So these are some of the interventions that we're able to bring forth within the last 3 years, 9 months that the committee has been functional.
Okay. Now I think you've given us a summary of the major things the committee has done, because I know there are some other ones too. There are some other engagements that were not among the ones you mentioned. I did know because I've been part of the committee, covering the committee. Now, the issue of national health insurance came. You know, this is one legislation that the Ninth Senate will be commended for. But you know, Nigerians out there, their own interest will be on the level of administration and management of that scheme. I know that sometimes Nigerians, the complaint they give about that scheme is the issue of standard of drugs. Now they approach their providers, head providers, provide for them. Now, do you think that the new act has or will address those concerns?
Yes, the act will address the concern. But let me just go back to say again, one of the challenges that's bedeviled the scheme before is in terms of the leadership and management of the agency as a body. If you recall, there has been a lot of attrition, what I'll call within short time the head of agency is removed, yes. Another one is appointed. In fact, the average survival rate was less than 2 years for most of
exactly.
the time as at 2019.
Exactly.
But the president appointed somebody, Professor Nasir Sambo, in July 2019, and I think there's been stability. Part of what his agenda that was delivered to him, which we have been working with him, is to reposition, rebrand the organization, and reorganize it in such a way that we're able to respond to the issues that we have raised. The Act has provided a framework, but you can have a law, you can have a policy. It requires effective implementation. What you talk about drugs, partially, it's not the fault of the insurance agency. It's also another thing which we are working on. It's about the local production of quality drugs. Most of the drugs we use in our countries are imported. So just like you said earlier, there are a lot of issues that we work on. Of course, NAFDAC is being supervised by the committee, and we had a lot of engagement on that. So one of the things that we are trying to look at, or we have worked on the last 3.5 years as well, 3 years, 9 months, is the issue of improving ability to produce drugs locally, working with the private sector. But specifically for the agencies, I think they have now developed what they call the essential drug list. They will be able to also work with manufacturers, particularly local manufacturers, to be able to see to what we call supply chain system. Because one of the things that make drugs to be costly, drugs may come in, but it should be the price that you're getting in Lagos that you get in Moda. But you can only even this if you have an effective supply system and you have a bulk purchasing system. So the health insurance, we are aware through our engagement with them, through our oversight, that they are working on that. The other one is the issue of backlog of non-payment of what we call it, capitation to the healthcare providers. The current management has been able to address that because we work with them. They had a lot of engagements with the various stakeholders, the healthcare providers, and they have been able to clear the backlog, which enabled the healthcare provider to provide better service now and be able to get paid as at when due. One of the challenges is also the issue of the health maintenance organization, HMOs, owing providers, despite the fact that the NHIA had paid them. Yes. So the current management reviewed that, they did an assessment, and they will actually revoke licenses of some HMOs. And through that, they were able to reposition the system, making the HMOs to be more responsive. They revoke licenses of those that are owing providers, because why people have challenge is that the National Health Insurance Agency paid the HMO to pay capitation to the providers, yes. But some don't pay, or sometimes it may be fee for service. Fee for service are for those services. Capitation is for basic healthcare, yes. But when it has to be required for you to get admission or get surgery, then fee for service. So some of the HMOs were owing months and years of unpaid remittances to the provider. So the new management reviewed all this. They asked them to go and reconcile. They gave them time to reconcile, gave them time to make payment. When they did not do it, they revoked licenses. So this has made the system. So I could tell you with some level of confidence that the system is better, especially in the last 2 years, than it was before, because of all these activities that are taking.
But did the committee, sorry for cutting short, did the committee at any point in time interface or engage with these HMOs?
We don't engage with HMOs. We engage with the agency, yes. Which provide. Agency is the one that reports to us. Yes. HMOs are. We did add engagement with HMOs when we are doing public hearings.
Exactly. That's the point I'm making.
Of course, for bills, so they are allowed to make inputs, and when there are specific issues, they are also allowed. Of course, we participate in some of the stakeholder engagement, but as a committee, we oversight the agency of government established to look at that sector. And that through that, we are able to ask relevant questions and give appropriate directive to them. That's why they are able to do what they did with the HMOs.
Okay, now this issue of bringing both the private sector into the scheme, how will you rate that implementation at this point in time? Because the new act has started, and basically one of the basic features is that it's now no longer only to the government sector. Now, how will you describe the implementation and expansion of that scheme?
I think it's slow in starting, but it's likely to progress with time. One, you see the basic minimum package, because the funding is from government fund. So it's the primary health care that are government owned that benefit from that money. However, the law, the current act, provides for what we call pluses. Pluses means beyond the basic minimum package. Individuals, private individuals can pay additional premium to receive that pluses, and they will do that either through HMO, through what we call third-party authorities, TPAs. This is starting. The national health insurance agencies are the ones to register those HMOs and so on for the private sector. The thing we are looking at is because majority of Nigerians are vulnerable, and it's the government responsibility to pay for their services. So for now, it's through the public health providers that is happening. But the discussion is already ongoing to expand, to engage the private sector, especially in areas, because it's not every area where you have the public being providing services. And this is happening in some states. For example, in Delta State, the government system is in partnership with private sector. There are private sector people that are engaged by government to manage even public health facilities. There's that happening in Delta. I think one other state has studied that and they're trying to do that. Lagos is also trying to pilot that now, which I'm aware of. So the private sector, you are saying, will be engaged and they will be there. I think what will make it to expand, which I hope the incoming government will do, because we hope we were thinking before, that in 2023 budget, the Affordable Group Fund will be put. But unfortunately, because of the level of indebtedness of the country, the budget itself was very small. There was no fund. We had engagement with the Ministry of Finance because they didn't put any fund for it. And then when the budget was being considered at the National Assembly, we had engagement, and they said, well, they couldn't. But we are looking forward to any next government to do that. Particularly, one of the things we are advocating for is substantial part of subsidies, if it's removed, should be pushed into that, because that will enable Nigeria. If we push it to that, it will enable about 83 plus million Nigerians to have access to healthcare.
Okay, another issue that actually needs to be addressed and need to be x-rayed is the issue of the foreign medics. You remember that issue? Your committee did take that issue very seriously. You engaged medical the people stakeholders, people involved. You know, this issue of medical doctors coming down here for retraining and some fees you are asked to pay, and you engaged. There was a meeting where you, at a point in time, you called for the suspension of that program.
Yeah, I think
so what is the state of that program?
No. It's not a program per se. It is a legal requirement. It is that foreign trained doctors, Nigerians or anybody, any other person who want to practice in the country, but you are not trained in Nigeria. If you are trained abroad, even if you are trained in Nigeria as a doctor, you have to obtain a license, which is given by Medical and Dental Council of Nigeria. But if you are newly trained, you just graduated, a requirement all over the world is that you must do what we call the internship, housemanship. It's housemanship. For you to do housemanship, you need a temporary license. If you are trained in Nigeria, in Nigerian institutions, because those institutions are accredited by the council, so in which case the standards, their training curriculum, their training content, and there is also oversight among this thing. Where you want to do exams, each institutions are compelled to invite external examiners from other institutions to be able to ensure and oversight and ensure that they are standard in the exam community. So when you are trained in Nigeria, it's like automatic for you. Once the institution gives you a certificate that you have passed, MDCN will give you a temporary license. You must have a license to be able to touch patients. But if you are trained outside, it's just like in any other country. If a Nigerian trained doctor wants to go to UK or US to practice or any other country, or even to Ghana here, every country you must do what we call exam, because they want to test your knowledge, your skills and competence to practice, to touch their people, to be able to treat the patient. So that's the same thing that's happening. That's what the law provides. So for foreign trained medical doctors, the issue was they have to do the exam. Now, what was observed, because we oversight all these exams, was that the failure rate was very high. And basic reasons, one of the reasons, not let me say basic, is because the training content, knowledge and competency of some of these trained doctors, particularly in some countries that are not English speaking, or they said there are some schools set up abroad, we are mainly training people for export. In which case, even when they train them in their country, they don't license them to practice in that country. So we have to protect our people. That's what MDCN is all about. So when we observed that MDCN itself, not even we, the failure rate was very high. So what they felt is that after training, before they go for the exam, they should have what we call a tutorial or a coaching for some few weeks or months, so that they will be able to learn about common diseases here, which we call it tropical disease, because the epidemiology of disease here is different from what is it in Ukraine or in Mauritius or Malta, where people go to train, because they may be training them on diseases that are peculiar there, maybe they don't know about here. And if you have to, the exam there will cover what is common here as well as what is all over, what is common all over. So the issues we are raising was that the MBCN now try to engage with institutions to set up this, what I will call coaching process, and they ask them to pay for that based on what they will pay the institutions. So when we now look, we said, MBCN, you are only an examiner. You are not supposed to train. So people are complaining the money is much, remove your hand from it, that's why we stop it. That it should be left to the student. Your own is, let students present themselves to you that I want to do your exam. So if they go through exam, it is them for themselves. But individuals or private sector or anybody can organize coaching for them and charge. But because we are government institutions, that's why people are complaining. So when you say the status is still that MDCN is not organizing any coaching based on our directive. They've cancelled it. So people go, they apply to do the exam, and the exam goes on. If you pass, you pass. But if you want to coach on their own, people are arranging whatever they want to arrange, we don't know about that.
So what was the state of that now? Is it as this committee
yes.
as
no,
committee
but
recommended?
Exams, of course, they do exam every 6 months. Next one I think will be in May, because the last one was in November. They do November and May every year.
Okay. All right. Thank you very much. We'll take a short break now. When we come back, the program continues. Welcome back to the program, the Standing Committees. I am Ignatius Unko, and the guest today has been the Chairman, Senate Committee on Health, Senator Ibrahim Oloriegbe, Senator representing Kwara Central. Thank you for still being with us.
Thank you very much. Yeah. My pleasure.
Okay. Now, your committee has considered quite a number of bills. In fact, in the Ninth Senate, hardly 2 weeks or a week passes without public hearing on bills by your committee. Now, some of these bills, can you tell us some of the highlights on some of these bills and some of your findings?
Yes, I think just like I said earlier, some of the bills, or let me first of all say that so far, as at now, about 59 bills have been referred to my committees. And all the 59 have been considered or processed by the committee. We have submitted a report for 55 of the 59. The other 4 that we are here to submit the reports are ready. We hope we'll be able to present it where we resume after the elections. The last, as you know, this week, we had a report on the National Medical Research Council bill. So I'm pleased to say that all our reports that we have submitted on the bills were accepted and passed by the National Assembly. Of course, not all the 55 that we reported back on. There are some bills that we and ourselves as a committee, after considering, we stepped down because we consider them that they may not be able to add value to the system. Now, it is pleasing to say that we've had several of the bills going through the process of the House and getting access. I mentioned some earlier: the National Health Insurance Authority bill, the Mental Substance Abuse bill, the Federal College of Complementary Alternative Means bill, and then the I think, let me just check. I've mentioned mental health, National Health Insurance. Of course, there's the Federal University of Medical Sciences.
Quite a number of health institutions.
That's what I'm coming to. The Otrupo was established without a legal framework before, but the bill has been passed. Then a bill, for the first time, we had federal medical centers established. I believe before we came here, about 21 of them. There was no law. So now we have a law for federal medical center, and new additional federal medical centers were established through. We have the Hong Federal Medical Center, Hong. We have Federal Medical Center in Wasi. Then there's Federal Medical Center. I think there's one other one. Okay, the Daura one was, because it was Kasina was proposed, it was stepped down, but Daura was approved. Then we changed the upgrading of some Federal Medical Center to Teaching Hospital, like the Modibo Adamawa University Teaching Hospital now. It was formerly Federal Medical Center in Yola. Then we have Teaching Hospital in Duse. We have David Demai Teaching Hospital in Boeing. These are new teaching hospitals that were created as part of our bill. Of course, there are lots that are still within consideration among the bills that we have passed. I've told you about Modibo Adamawa Teaching Hospital. So a lot of our bills have been passed to the House of Rep also for concurrence. We are waiting concurrence. Like as I told you, we have the Medical and Dental Council amendment bill. We have the Nursing Council amendment bill. These are all before the House. The NAFDAC bill has been passed back to us. I hope by next week we are going to take an amendment bill for that particular agency as well. So, okay, the one I was trying to mention, the Psychiatric Hospital amendment bill, which was one of the bills I moved earlier in the life of this assembly also. And that one has led to the establishment of an additional psychiatric hospital in my constituency in Kwara. Because hitherto, in the whole of the North Central State, yes, North Central, there's no federal psychiatric hospital. We had before now 8, that's before 2019, 8 federal psychiatric hospitals across the 5 out of the 6 geopolitical zones. We have 1 in the northeast in Maiduguri. We have 2 in the northwest in Kaduna and Sokoto, Kware. We have 2 in southwest, Aro, Abeokuta, and Yaba, Lagos. We have 2 in south-south, in Calabar and Uselu in Edo State. Then we have 1 in the southeast, which is in Enugu. So the whole of the 6 states of North Central had none. So this gap was identified by me, and I proposed the Secretary Management Amendment Bill, and that bill was passed, and the Neuropsychiatric Hospital in Budegba, Kwara State, was established. That's part of the work of myself and using the committee, instrumentality of the committee and the president. The hospital is already up and doing and functional now. I think about 8 new federal institutions have been established as a result of the activity in the last 3.5 years of this committee. I've mentioned some of them. Some were teaching hospitals, some were federal medical center. The 3 additional orthopedic hospitals were also established in the last 3.5 years. One in Jos, that's for North Central, because hitherto also we had 3 orthopedic hospitals in the country. Kano, Lagos, in Yaba, and Enugu. So Northeast had none, so there's 1 now in Northeast, which is in Taraba, Jalingo. North Central had none, it is put in Jos, and then South-South is put in Benin. So these are some of the these are some of the activities of the committees in terms of the bills we consider and how this bill went on to become law, how the laws were implemented, or in terms of the establishment of these hospitals. All these hospitals I mentioned, in the 2023 budget, they are all funded. They all have now funds to be able to start. Of course, the psychiatry hospital has started hitherto since last year.
So some just wanted a legal backing.
No, some of them are legal backing,
Yes.
but what I'm saying, they are newly established. It is not legal backing alone.
Okay. I mean, like some of the like the ones that one or two you mentioned.
No, the federal, of course, the entire federal medical center before had no legal, like the Otropo was legal backing because it was established before. Of course, we passed a law where we wanted the establishment of at least one, medical science university in each zone. The reason is because we need to produce more health workers. Given our population, yes, we are having people exiting the country, but we cannot stop exit. It happens to be country like us, India and so on. The thing is that we need to increase our production. If we produce more, we have more to be retained, and we have more to distribute across the country. Because in terms of the availability of health manpower, there's maldistribution. The northern part of the country has a very minimal, so there's a lot of wide gap. So our thinking, which is what we have proposed, it's been passed, is awaiting presidential assent, is to have at least one federal University of Medical Sciences to train various categories of health workers. As I said, Otrukwa has been established. I think one other one has been established as well among the 6 that we are proposing. So this is part of the work or the committees have done.
Well, Senator, out of these bills you've all mentioned, I do know that some of them were sponsored by you particular. So how many bills did you sponsor, and what are the status of these bills?
Well, in terms of the health sector, I have 11 bills that are sponsored, but I have other bills that are not related to the health sector. I think about 4 or 5 of them that are in other sectors, education, agric, and as well as civil society. For the health sectors, I have health bills sponsored. Out of these, I have 11 bills sponsored. Out of these 11, 10 of them had been passed by the Senate, and 4 has been given assent and become law. So the bill includes the National Health Insurance Authority Act now. Okay. There's a bill that's sponsored by me. The Mental Health and Substance Abuse Bill, which is now Mental Health Act, that has been passed and then assented to by the President. Federal College of Complementary and Alternative Medicine of Nigeria, which establishes a college for the complementary. The college has been established before, but it has no legal framework, so it went into dormants, and there's budget provision for it, so we now provided the legal framework for it. Then, of course, the Psychiatry Hospital Management Board Amendment Bill. The bill was sponsored for me to be able to get an establishment of a psychiatric hospital for North Central, which is located in Oloriegbe and Kwara State. But in addition to that, as I mentioned earlier, we had 8, now it's 9 with the 1. Only 3 were mentioned in their former bill. And then the bill is archaic because it provided for only one management board. Whereas practically now what is happening is that each of the hospitals have a management board, so there's no legal framework supporting what is happening. So the bill not only established a new hospital, it also provided for legal framework for management of all those 9 hospitals as it is now. The other ones which have been passed awaiting concurrence is maternal and perinatal death surveillance and response bill. Essentially, this is to be able to provide a policy framework to look at the causes of maternal health or death of newborn and find out that cause to prevent it, because the death of a woman during pregnancy or childbirth is an indicator of the performance of the health system of a country. So an audit of this and prevention of it is a very essential thing to improve healthcare. So the National Emergency Medical Services Agency Bill, which I mentioned earlier, was sponsored by me, has been passed. Medical and Dental Practitioner Act, essentially that is the law that establishes the Medical and Dental Council of Nigeria. And it's a 1988 law. So a lot of things, a lot of development have happened in the sector. So this bill tried to bring up to date, has been passed by the Senate. Then we have the National Health Act Amendment, which I mentioned earlier, which is to be able to address some of the challenges, including addressing the issue of the council, what we call National Health Council, addressing the issue of the amount of funding to be allocated for basic health care provision fund and the sharing of that. That has been passed by the Senate as well. Then the Nigeria Medical Research Council is the last one, which was passed just this last week by the Senate. Now there's only one which I didn't pursue further after first reading, which is the Complementary Alternative Medicine Practice Bill. It is to be able to establish a board for traditional and alternative medicine. But why this bill, the one I sponsor, the Federal Minister of Health said the Federal Health Council is considering a bill. Two, the alternative and complementary medicine is currently being regulated by Medical and Dental Council. So these issues are the things we are trying to resolve. But I'm pleased to say the Federal Minister of Health has submitted an approved traditional practice bill, so which will take up before the expiration of the tenure of this assembly.
Do you think that bill will be able to be considered in the next 3 months?
It should be able to. The Medical Research Council, I said to you, we started it in January when we came back, and we've passed it now. So we'll pursue it. I'm sure when the House of Rep come back, we'll be able to do the necessary engagement with our colleagues in the House to get it. But because we already had a stakeholder engagement, in which case the executive already have a buy-in. After the public hearing on that bill, we invited the Minister of Health, we invited all the stakeholders. So the final report we submitted is an agreed bill, which will not have any objection from the executive when it comes to them. So that's why I said it can have assent. Once you want a bill to get assent or to get a presidential assent, I don't want it to be objected to by everybody. In the process, you engage very well. And once you engage with the process, you have an agreement. So these are the health-related bills.
Apart from the health sector, this Night Assembly has witnessed quite a number of bills assented to. Now, what do you think is behind that? Is it one of these reasons you gave?
It is. It is because of the, as you know, we always do say that we complement each other, the parliament and the executive, the legislature and the executive, so to say. If there's complementarity, you'll be able to achieve more. You can see that a lot outside even the health sector, there are key bills that were passed by this assembly, which for 2 decades have not been passed. The Petroleum Industry Act, which was the Petroleum Industry Bill before, has been in the parliament since the days of President Olusegun Obasanjo. I think the first was 2000 or thereabout. The Electoral Act was passed about twice before in the last assembly, but this assembly was able to get it across. There's another bill which is in the petroleum sector, which has been not the PIB, onshore. We were able to get it across. The Commerce Bill and so on and so forth. So, of course, I have one of my bills is an amendment to Commerce because the areas where it is being where there are challenges, where the civil society organizations are raising issues, it's not a bill as possible. It has passed through second reading. We have had the public hearing. It's my hope that when we resume, we are going to present the report. I just discussed with the clerk. So, to go to your question, most of the bills that I sponsor, and particularly in the health sector, what we do is after the public hearing of the bill, or during public hearing, we get stakeholders involved. And now, before the committee finalizes its report, we hold retreat to engage with all relevant stakeholders so that we have consensus on the issues that are in the bill. For example, as I told you, like the National Health Insurance, when it was passed by us, it was rejected by the president. We have to find out the reason. The 2 reasons were 2. One, that we created a tax, which we said the taxing of use of mobile telephoning, and we said the money should be collected by the National Insurance Agency. So the finance raised this issue. One, you cannot create a tax for a sector. Any tax that will be created should go to the post. 2, it's only Federal Revenue Services or the custom, as the case may be, that are, by financial regulation and by finance law, charged with responsibility of collecting taxes. So any other agency cannot collect tax. So we agree on this, and we have to remove that. So the only thing is that we have to look for other sources of funding for the vulnerable group. Of course, that's why we are now pleading, not in the law, but through policy to say if subsidy is removed, a percentage of subsidy should be allocated to that. Okay. So the thing is, for a committee to get its work done, you need to engage. we need to have discussions and agree. Once that is done, there will be a smooth sale of the proposed bill through the parliament as well as after the parliament when it gets to executive, because that's why there is this check and balances. For anything to come law, it's only the parliamentarians that can propose bill, but the president has an assent power, and he can withhold that asset. Of course, the asset may be override, but you know that's very difficult because you require a two-thirds of both parliament. So it must be. I mean, you work in the parliament.
It's not a walk in the park.
Yeah, no, it is not. It is not. So it's always easy for you to have an agreement and address any gray area. Like that's what I think that's what makes the National Assembly to be very successful. Okay. So most of these bills that we said, it was through engagement between the parliament, between the legislature and the executive and other stakeholders.
And I do hope that the 10th National Assembly should queue along that line.
I think that with what has been, the foundation that has been laid, it's my hope that that will continue. Okay. Because it's good for the country, it's good for everybody.
Now, as a practicing medical doctor, are you not worried at the level of mass exodus of medical practitioners out of the country?
I'm worried not just as a doctor, but also as a leader within the government and within this health sector. Everyone is worried. Just like I said earlier, yes, we are producing, but the rate of exit, in fact, like now superseding what we are producing. At the end of the day, it is us as Nigerians that are suffering. But the causes of it is beyond the health sector. The cause of people exiting include, one, the issue of economy, wages. And wages is not only health sector related. Health sector on its own cannot decide as to what it pays. Health sector operates within the framework of the national wages system. So except and unless the system will give a special recognition to the health practitioners, the healthcare workers to earn specially so that they can live better and then be able to stay. So it is the economic, their economic reason is because they are able to earn better when they go out of this country, hence they go out. But there are other issues beyond earning. There is the issue of security, or insecurity, so to say. Because health workers, particularly you only mention medical doctor, we have nurses, we have pharmacists, lab scientists, everybody is living. They are highly trained, and as such, they are a group. They are part of the elitist group of any society. And when there are insecurities, they have that challenge, they have that fear for their families and so on. This makes people to live. So in which case, it's beyond the health sector. The country has to be able to address, or government and everybody in the country to address the issue of security and stabilize the system so that people can stay to do better. Now there's also the working environment. Because healthcare worker works not only in urban area. If you're a civil servant and so on, an engineer, you can decide to say, I only stay in urban area. We have health centers across the villages and rural areas where you need nurses to work there, where you need doctors to go there. If a doctor or a nurse will have to stay in a rural area, such a doctor or a nurse will look at my family, my children, which school do they go to? Will I have a good source of water? Where will I get electricity and so on? So providing that enabling environment that enables people to have peace when they are working will enable us to be able to retain more people. So these are the issues. So, but with the one that relates to the health sector itself, I think we are working on that. We've done a lot of work, like that I said, like the residency training fund that was provided by government. The issue they've increased now, I think some of the allowances that are paid doctor, but it's because of relativity, because some allowances in civil service are also increased, they increased that. But beyond that, I think to be able to address that, the sector is also looking at what we call task shifting, which is to be able to delegate certain functions of health workers to some other health workers that are not of the same level of qualification but with skills. That is to be able to identify specific skills and say, you shift this task to such cadre of health worker to be able to care, enable care for people that they have to care for to prevent death and prevent illnesses.
That's it actually. But I think this also brings to mind the issue of our leaders, the well-to-do in the Nigerian society. Everybody always going outside to seek for medical attention outside. Are there times when this will come to an end?
I think it should be. it's one of our, I didn't mention earlier, one of our agenda, which we did not accomplish, is to be able to establish at least one center of excellence in each geopolitical zone. It was something we proposed, but lack of funding made it not impossible. But let me say that in this country, we do have manpower. Because many people, that they go out also, we found out that it's Nigerians that they meet, either as doctors or nurses, particularly in the UK. We have over in the US. So, but two, what I see happening, why it will end is that there are a lot of private sectors setting up this system. About a few weeks ago, the Healthcare Federation of Nigeria, which is an umbrella body of private health, not, it's not, I mean, I would say stakeholders, because it involves manufacturers of drugs, it involves people that own hospitals, it involves people that are practicing special suppliers of equipment and so on. They held their annual conference, and during the annual conference, they shared what is going on. I can tell you that we're already having medical tourism from outside Nigeria, people coming from especially African countries because of specialized services that are established, particularly in Lagos area. There are people that have established things, and then using technology, what we call telemedicine. There are Nigerians who are skills that are outside, and they're able to provide support to people in Nigeria to provide care. So specialized care already, there are specialized hospitals, particularly in Lagos. And during the discussion we had, then we said it should spread it to other parts of the country. One of the, what do you call it, I can call the sponsors or proprietor of such system, said they are already thinking of establishing Kano, and they'll go to Port as well to have this. So when you say I think in the next few years, I can foresee that. But more importantly, it should be for the government to provide an enabling environment and facilitation for this to happen. The policy and the plan we have to have at least one center in each geopolitical zone that can be designated as a center of excellence to provide specialized services that make people.
But do we have any at the moment?
We don't have any.
So the National Hospital here in Abuja is not one?
It's not one yet. It's not, because there are certain, because what is there is that to be able to have, we do have elements of that. There are specialized skills, there are skills that are human, there are equipment also. But where you have integration, when you talk about such a center, it doesn't mean, for example, if you need something to happen, you may not have the doctor and so on, and it does happen briefly. It may not be in the president in Abuja, but the person can fly in from Lagos, come and do whatever the special, if it's specialized surgery, go back, but it needs to be coordinated. Then there are other, what makes people to go abroad sometimes, it's not just the doctor, or it's also about what we call the hospitality of the hospital. So this hospital tries to provide, but it's not yet there. Hospitality means you have wards and so on that are like hotels, where you have the standard of any hotel, so because that's what people pay for outside the healthcare itself. So these are some of the things that can happen. And when such happen, our own proposal is that such centers, if the government facilitate or enable it, whatever resources that are generated there will be used to subsidize for what the services for general people will be there. Okay. Because people that go abroad, they have the resources, but they can use that resource. It's cheaper for them to do it here. Yes. That's why I say, well, that's what's happening in Lagos now. Very many specialized services are being provided. So because the cost of providing services alone will be just at the cost of the ticket that the individual takes to go. Cost of ticket will be enough to you for you to get your care if it's in Nigeria. Not to talk of other services that we pay for.
Okay. Now, your committee at a point in time became so interested in ensuring Nigeria involves in local production of syringes. You moved in for that. What is the status of that, your advocacy?
No, we submitted a report. The Senate approved the report. The Minister of Trade and Industries was engaged. He said the policy is ready. But the thing is about the backward integration policy, yes, to enable local producers to be able to. So, but it's still hanging between the ministry and Federal Executive Council. I think it's about 3 months ago I engaged the minister. We hope before the expiration of the listing, because he said the policy has been developed, but they have taken it to council, it's not been listed. That's what he said. So, as a committee, we did our own, we gave this, and we followed up. So it remains for the Federal Executive Council to approve it so that it can go. In fact, about 2 weeks ago, that one of the members of the group had a discussion with me to say there's a new established producer that can produce, I think it's almost close to 1 billion pieces of syringe in a year. It's a new factory set up in somewhere in Ogun State. So in which case, even the gap that we said that we had before, most of it will be filled by that factory. So we are following up, just to be able to, that's why I'm able to tell you about this. So we are not relenting our effort to oversight and see to it. But sometimes we push, you have to as much as we can. So it's not as if we have any kind of sanction beyond it's not advocacy alone, but beyond the fact that we need to, because it's the executive function. It's not our own duty.
All right. Thank you very much for your time.
Thank you very much.
Well, in a few months' time, the 10th Senate will take off, and Senator Ibrahim Oloriegbe might not be part of that assembly. How will you describe your experience generally in the 9th Senate and going off the chamber for now?
I think it's been a very worthwhile experience. It's been fulfilling, and it's been, as I said, it's been something that add more to my experience, and I'm fulfilled because I think I've been able to contribute my own quota to the development of this country, not only in the health sector, because I belong to several committees, and through those other committees, I'm able to make useful input and impact. But beyond that, I'm also fulfilled because I'll be able to do quite a lot for my constituency who elected me. I've mentioned a few, but far beyond that, I've been, in addition to the hospital that is established, I'll be able to take more federal presence. The National Health Intelligence Agency now have an office in Kwara, which is finished. NAFDAC has office in Kwara. I'll be able to enable the construction of a comprehensive health center, which is taken over by federal government as a satellite station to University of the Hospital and as an emergency center along the expressway between the north and south of Nigeria. Several schools were built, several schools were equipped, the area of water, the area of electricity, and so providing transformer. So I'm very fulfilled. Yeah. So, but what is there is that as I exit, I think service continue. Before I came to the Senate, I'm still a medical doctor, and I've worked in the health sector in the last 30, before I got to that, about 35 years before I got to the Senate. So through the services in the sector, both as a medical practitioner, as a public health physician, working in the public health domain, I've been providing service to humanity. So service continues. So exiting the Senate, it will be for me to put the experience that I've gathered through there to be able to provide service to our country and to humanity in general. Thank you very much.
Thank you very much. Nigeria can't wait to have more of you, this time around in another sector, another part of the government. And with that, I will say thank you for your time.
Thank you.
Chairman of the Committee on Health, Senator representing Kwara Central Senatorial District, Senator Ibrahim Oloriegbe, thank you for coming to the program.
Thank you. My pleasure.
Well, this is where we'll draw the curtain on today's episode of the program, The Standing Committees. I am Ignatius Nkwo. Enjoy the rest of our programs.